Thanks for having us. So, Chrissy, please, over to you. Thank you very much.
Brilliant. Thank you so much. Now we can kick off with the really exciting part of our meeting. Very glad to introduce our first speaker, Danielle Antonellis, who is the founder and the executive director of Kindling. And Kindling, if you don't know, are a US-based non-profit organization. They have a mission of connecting fire safety knowledge to local and global humanitarian and development efforts so that we can all reduce the unequal impact of fire on people, property, and livelihoods in vulnerable communities all across the globe. Danielle will speak to us about fire safety for all, pathways for burn prevention, and just as a nod to the recent work that she's done with the Global Shelter Cluster, if you haven't seen the two published documents on the fire risk reduction guidance and the state of the fire safety in humanitarian shelters and settlements, you really should check that out. But for now, I will pass you on to Danielle. Danielle, the floor is yours.
Thank you so much, Chrissy. It's wonderful to be here with you all today. Nice to be able to see faces right before I talk, so I know there are real people I'm talking to. That's always a really nice thing. I'm going to share my now. Please, if someone could just confirm that's working.
Yes, it's working, Danielle.
Perfect. Thank you. Okay, so as Chrissy's mentioned, I am the founder and executive director of Kindling. I'll give you a brief introduction more to Kindling around our mission statement. But today I really want to focus on the discussion of burn injuries and deaths. So the question that I was kind of raising to myself is, what is the connection between fire safety and burn injury prevention? And the title of the talk is Fire Safety for All, Pathways for Burn Prevention. So I'm trying to make an argument that we need to work together much more collectively around fire safety and burn prevention. As Chrissy already shared, the percentage of people that are affected by burns and also by fire more generally is disproportionately felt in different communities, in different states, in different countries, by different people within the same communities. Health inequity is a very strong lens for burn injury, and fire safety inequalities, as I term it, is a very important topic around the world. We see that 95% of fire deaths occur in low and middle income countries. This is a significant motivation for the organization of Kindling being started in the first place. So Kindling was founded in 2020. So we're about 3.5 years old. We're still a young startup nonprofit organization, and we are all about fire safety. So our mission is to connect fire safety knowledge to global and humanitarian and urban development efforts in order to reduce the unequal impact of fire on people, property, and livelihoods. We focus on vulnerable communities around the world. Most of the examples I'll share now are going to be focused on low and middle income countries. However, we do also work in high income countries. For example, we do work in the US around homelessness, as just a quick example. But largely we're working in the humanitarian development sectors. So on the screen, you can just see a few photographs of the types of contexts that we work in. Refugee camps. We have in the bottom left-hand corner, you can see an informal settlement. This one is in Mumbai. We have informal settlements in all different parts of the world that look very different. So they're very, very diverse settings that we're working in. People are generally living in marginalized conditions and suffering from poverty and other types of deprivations. And fire is an added risk, right? They're suffering daily from other issues, and then fire becomes a large shock in their life when it does happen, and can be a significant event in their life if they get burned, but also if they lose their property, if they lose their home, if they lose all their belongings. I want to just point out on the top right hand of the screen, this is a picture from a fire that happened in Iraq, and there's a quote that refers to people saying this fire was more traumatizing for them than when ISIS attacked them. So we are certainly going to be talking about physical injuries today, but I also just want to point out the very real mental toll that this takes on people that are living in very vulnerable conditions. And along those lines, I just want to share this quote that was used around Hurricane Katrina. This was something that was posted around certain communities. It's also been used in Northern Ireland, but it's kind of something that resonates with me and I think about a lot with our work. I'll just read it out loud to you. Stop calling me resilient, because every time you say, oh, they're resilient, that means you can do something else to me. I am not resilient. A really important framing for our work is through looking at fire as a disaster. So we frame fire through the disaster risk reduction lens. And what that means is that fire is not only a natural hazard in a wildland situation, it's also, as they would call, man-made hazard in a urban environment typically. But we also have significant social, political, economic, and other types of vulnerabilities that combine with that hazard to create disaster conditions. One of the projects, actually the first kindling project we ever had, was exploring just that. How do hazards and vulnerabilities come together to create fire risk in informal settlements? And we were looking at Dhaka, Bangladesh, and Cape Town, South Africa, which is where I'm currently sitting, to try to understand how fire risk emerges in these very different settings, but which share some common physical challenges around the built environment, the types of cooking, heating, and lighting that are used. And so we carried out a project, and we continue to work in these places around trying to understand how risk emerges, as well as understanding how fire safety is governed. We find that it happens in many different ways, in both formally and informally. And one of the activities that we did through these engagements was we actually mapped out what fire safety emergence looks like to us. And when I say us, I'm referring to Kindling being not only an organization that has engineers like myself, but also social scientists, disaster studies specialists, architects. We have people coming a little bit from the medical sciences, although one of the points I want to get to is that we actually are really lacking in our engagement with public health and health in general. So that's one of the reasons I'm really excited to be here. And so anyways, the group within Kindling and our collaborations, we set out to map some of the emergence of risk. Obviously, this is really small, and I'm not going to ask you to look at all these little dots and try to explain it to you. I am sharing the report download here, but I wanted to point out a few things, because as I was trying to prepare for this talk, I was imagining the linkages, and there really are many, many connections, and there's obvious ones, right? So fire is obviously the cause of many burns, but when we talk about fire, we don't just talk about it generically. We really try to break that down and understand how the risk is created, how people experience fire, what the consequences are of fire, and how that creates feedback loops to create further fire risk often. So that is exactly what this conceptual map is doing. It's looking at fire risk both before an incident, during an incident, and after incidents. And again, I'm not going to ask you to look at the little dots, but I do want to zoom in on a couple things just to make a few points. So in this first slide, we are in the top of the screen, so the pre-fire stage. And within there, we can see that social determinants of health, access to healthcare, are directly contributing to the health conditions that people are currently of populations. And combined with age and disabilities, this all contributes to the physiological and psychological vulnerabilities that people might exhibit before a fire ever occurs in the first place. On the left, where we're not going through the mapping in detail, there's a lot of discussion around how fire hazards are created. So that also relates to social determinants and access to different services. So I want to just really emphasize that these kind of gray circles are really critical when we look at who gets affected by fire and how. And I think there would be a direct relationship between who gets affected by fire and therefore who is burned, and what does that mean for their lives, of course, goes into the post-fire incident. So here we look at these factors, and there's a lot more I think that could be expanded on. If you saw the earlier map, it's this little tiny part on the right-hand side of our screen where we're looking at the kind of the people's vulnerability, their physical and psychological vulnerabilities. But if you look on the left part, there's so much more that we know. And I wonder how much of this is because we're actually not collaborating enough with people who are on this call. When we go down to fire consequences, we see several different types of consequences of fire. And of course, the most tragic are fatalities and injuries. We see that injuries can translate to fatalities, and that's often a function of whether or not there's access to first aid and ambulatory services, access to healthcare, including burn care, and that can be a very long-term type of burn care that's needed. There are people on this call that are much better positioned to share more around what burn care is needed and how that changes people's quality of life and what type of support they need long-term, because this certainly isn't an acute need for healthcare. It's a very long-term chronic need. So there are many opportunities to improve these systems. And unfortunately, there's a constant risk that people who are injured in a fire will later on suffer and potentially even pass away because of that situation. And also that we see a lot of people will suffer from trauma and other mental health impacts from their injuries as well. Again, you can download the report here for more detail, but I just wanted to point out some of these key connections from our work. But moving on to another piece of work that is really motivated by this one quote, and speaks to, again, why kindling exists in the first place, and I think why organizations like ADN, or sorry, networks perhaps, but like ADN may exist. I have a feeling the sentiment's probably shared beyond fire and even burns. Fire is everybody's problem, and therefore it is nobody's problem. This is a quote from a focus group I hosted, must have been 7-8 years ago now, with a group of humanitarians to try to understand why fire safety was neglected as much as it is in the humanitarian sector. And this really stood out at me and has really shaped how I look at fire in general. And if we apply this specifically to the humanitarian sector and start to look at it more discreetly, we can learn quite a lot through this one quote. So if we look at this diagram, it's actually representing coordination for internally displaced persons in humanitarian settings. So you can see there are 11 different pieces of the pie, such as shelter, nutrition, health, etc. These 11 different clusters, we call it, are the groups of agencies that respond to different humanitarian crises to provide support to the affected populations. So essentially, before this system existed, there was a lot of duplication of efforts and gaps in humanitarian action. And so there was a system created to try to coordinate and have more efficient allocation of resources so more people could be supported in humanitarian relief and response. So we have these 11 different clusters, and like other disaster risks, fires do not clearly sit into any one of those pieces of the pie. There's clearly a need for shelter practitioners and agencies and funders and donors to be thinking about fire, because the materials they choose for construction and the way that they lay out the shelters directly affects fire risk. There's a need for emergency telecommunication systems to be involved in fire safety as far as communications during a fire incident, for example. What happens if the warehouse with all the food in it burns down during a fire event? And what does that mean? And I want to point out health in particular as well. You know, when people are negatively affected by a fire, when people do sustain injuries, or they have other types of injuries from the fire that could be directly from the fire and smoke, or it could even be indirectly from the commotion during a fire event, the health sector is where they go. But there's not coordination currently between all these different clusters to actually consider the cross-cutting nature of fire and to address it in a systematic and holistic way. This is a quick kind of diagram to describe the problem and how it emerges. So, you know, we can look at some of the pictures I shared earlier and see a very difficult situation in a refugee camp, for example, where there are very few choices that can be made to change the physical layout of the space. And therefore people often will say, oh, once a settlement is already existing, there's not much you can do. I would certainly challenge that and say, actually, there is quite a lot you can do. You may not be able to change the built environment, but you certainly can change people's understanding of critical issues. One area where burn injury and fire safety cross over really strongly is around cooking, for example. Not only thinking about cooking as a potential source of fire ignition, but also direct burn injuries from the cooking activity and the opportunities that present themselves to collaborate between those two goals of fire safety and burn injury prevention in the way that we engage. But also when you start to think about the development of settlements, you can start to look at, okay, what are the opportunities at different stages throughout that development to avoid the creation of fire risk in the first place? As I mentioned before, we work through disaster studies lens, which means we talk about fire risk reduction, and we look at current situations and try to reduce risk. But in the humanitarian sector, we're actually pointing out that fire risk is an unintended consequence of the humanitarian assistance in the first place. Because as we seek to find shelter for people and provide healthcare and do all these really necessary and critical things to support humanitarian needs, sometimes we're actually putting people at adverse impacts of fire. For example, we see that hospitals in some of these refugee camps are built with very unsafe materials. And that can create other issues. Or during COVID, we had a lot of oxygen being used in these hospitals without appropriate fire safety considerations. So the point of this and the work that Chrissy mentioned is really to try to identify that there are things that can be done. So in the same sentiment of burn injuries and deaths are avoidable, you could apply the same to fire safety. Fire risk reduction is possible and fire injuries and deaths can be avoided. I want to just share the QR code for these two reports that are launching next week. And I do want to just kind of do a little cross promotion to be a little bit cheeky, to say we hope you can also join if you're interested in learning more about fire safety in the humanitarian sector. This is the link. I'll put it into the chat as well. And please do let me know if you have any interest. I'd be happy to chat more. And finally, I just wanted to make one last point about the approach we take at Kindling, which is really focused on bringing together different types of knowledges to reduce risk. And we really center the communities that are affected. We can't just do kind of physical science and engineering academic research and expect that to make a difference. We work really closely with academics and we have academics within our own team. So it's not to say anything negative, it's just to say that when we work in silos, it doesn't help anyone. We need to actually work on how do we break down silos, bring together operational knowledge, whether it's humanitarian operations, fire service response, how do firefighters actually operate in these environments, whether it's city operations or disaster management, together with the physical sciences and engineering, and critically with experiential knowledge. So in Kindling, we have social scientists and their sole focus is how do we bring in the experiential knowledge of communities and other actor groups, and how do we use that as a basis to collect evidence and make better decisions and help support all the different key actors, including communities that are affected directly, in making better decisions to improve their safety. All of this is grounded in contextual knowledge, which is arguably the most important thing. You might have something that works in Dhaka, Bangladesh, and it will not work in Cape Town, South Africa. So how do you understand what is contextual? How do you decontextualize and then bring it to somewhere else? But really important is local, right? So as an organization, we operate in a global stage, but we're very much trying to create local hubs of knowledge and support and the kind of knowledge exchange that was talked about with ADN is a principle of how we work as well. And I don't have time to share more about that, but very much about supporting those types of collaborations. And I just want to point out again, there's a real need for us to engage more with the medical sciences and health professionals. As I was looking at this diagram and preparing for today's event, I realized that maybe there's even an entire circle missing, where physical sciences and engineering is, or maybe that's too narrow, and we need to be thinking about science and engineering and health more generally. So yeah, just kind of food for thought, maybe for the discussion. I'm really interested to hear how other speakers and other people that have joined this event think that we can work more collaboratively around research, advocacy, pilot projects, education. So I'm really excited to talk about opportunities to collaborate at the local and global stage. With that, I'll just thank you for your time and hand back over to Christy. Thank you.
Thank you so much, Danielle. That was really insightful, and I'm so glad to see your reports featuring and your work featuring, because it sets a really good perspective on what we're all trying to do here. And I already have a lot of questions, but I would encourage all of you as well to use the chat to put some questions that we can then pose to our speakers towards the end. So thank you, Danielle. We are going to move on to our next speaker, who's Dr. Tanveer Ahmed, who is a Bangladesh-trained plastic surgeon. He's an associate professor in Sheikh Hasina National Institute of Burn and Plastic Surgery in Dhaka, Bangladesh. He has special interest in reconstruction, burn, post-burn, hand and congenital and pediatric plastic surgery, as well as wound care. Now, Dr. Tanveer is going to be talking about changing trends of electrical burn injuries in Bangladesh. When I invited him, and bear in mind, these are very esteemed colleagues who are very busy in their clinical work, and I wrote to him saying, would you please come and join us on this very important webinar. I'm just going to read you the little line of his response. He said to me, "Thank you for your invitation to join your webinar as faculty. I'm happy to join, as I'm very much willing to work for reducing the burn-related deaths to zero." That gives you a really good background into what kind of human this particular surgeon is. Dr. Tanveer, the floor is yours.
Thank you. Thank you, Krishu, for a very nice introduction. So I'm just directly entering into my presentation. Actually, as you know, the most of the burn incidences are now happening in the third world countries or the low and middle income countries, and particularly prevalent more in India, Bangladesh, Nepal, and some part of Africa. But there are some increasing changing trends we are actually experiencing in our situation, because in recent years, due to the rapid development, we are facing different sorts of burn injuries in our center. Like the electric burns, the LPG burns, and the gas cylinder burns or industrial burn injuries. They are rising very rapidly. And all of those cases are really, really very devastating, because the salvage of the life is a challenging one, because most of those cases actually associated with the inhalation injuries or the facial burns, and more importantly, very devastating burns. So I'm working as the associate professor over there, and in the Sheikh Hasina National Institute of Burn and Plastic Surgery. We have a triple role over there. We are the clinicians as well as the trainers for our trainees. And this is the largest center for the training of the plastic surgeons and the burn specialists, and as well as the administrative works. And this is our hospital, and it is a brand new hospital. It just launched just before the COVID, and it is a 500 bedded individual hospital, in the public sector, that is the government sector of Bangladesh, and having 500 beds and considered as the largest hospital in the world. And we have all the facilities for the burns, and we deal with all sorts of burn cases, starting from the pediatric burns to the elderly, and we have the burn critical cares and the burn with pregnancy and women and everything. And as you know, the Bangladesh is a very small country with a big population. And as like other developing countries, we have several problems, like in burn, trauma, congenital, and the cancers. And in our center, we deal everything, but burn is a big challenge for us. In our country, it is estimated around 0.6 million burns per year, and more than 2,000 deaths is the estimated thing. But in recent years, in our hospital, actually, in a year, we used to admit 6,000 burn patients. But in our outpatient and the emergency department, per year, we handle around 50,000 patients with burns. In our recent statistics from our hospital, from the attended patients, at least 1/3 are from the electrical burns. This is the changing trend in recent years, that the electric burns are rising very rapidly, and it is taking the place of the flame burn. And these are the challenges, and they mostly affect the upper limbs, because most of those electrical burns are occurring into the workplaces, and most of the young people are suffering. And the reason behind it, like other developing countries, there's the unplanned electrical wires. But very recent, the Bangladesh government has taken the initiative to bring all the electrical wires under the earth. And in that line, in last year, in the Dhanmood area, they are able to actually bring all the electrical wires under the earth, and it's the beginning. So hopefully it will be completed by next 3 to 4 years to bring all those electrical wires under the net in the capital at least. And another thing is the rapid urbanization and rapid development. So we have lots of developments are going on. So electrical activities has increased, and the lack of awareness is the main challenge for the developing country or this part of the world. People are not so much aware of their own safety and these things, and the reluctant to use the safety gears. This is the main reason behind the electrical injuries. And in 2021, we faced a big disaster in an industrial area just next city to Dhaka, and that is our neighboring district, that is the Narayanganj. And at 8 p.m. in the night, we received around 300 burn patients from the district, and actually we tried to accommodate those patients in our emergency department. Then we rearranged our outpatient department and our post-operative wards and converted those areas for the trials. But you understand, the most of the cases are so severe, we are not able to save most of the lives. By the end of the morning, we lost around 40 lives out of those 250. And if you consider the things in our setup, at least most of the cases from the adult cases and even with the upper limbs, but pediatric burns are not rare. At least 1/4 of those cases are from the pediatric group. So these are the devastating pictures of the electric burn, how they are damaging the limbs of our people. And what I was telling from our small research, we found that most of those cases are from the workplace, and followed by the household electrical burns, and those are mainly involved the pediatric groups. So if we are able to create the awareness among the workers and the electrical workers and the industries, we'll be able to control the incidence of the electrical burns in those areas. And if you see, these are the some charred limbs. This patient actually appeared immediately after the injury. So how shall we save this limb? There is no way. Even we are not able to save the life, because these sort of limbs are so damaged that we are not be able to salvage the limbs. And most of those people are from the working the population and the young population. Most in many of the situation, that young guy is the only earning member of a family of 3 to 4 members. So when they lose their limb, they become unemployed and actually like a barrier, or they becomes a burden for their own family. But whenever we save some patients, but in most of those cases, their affected limbs actually ended up on with some amputations, and at least 50% of those survived patients undergo amputations, and mostly into the upper limbs. Not only a single limb. In many of the cases, we actually experience the amputation of 4 limbs, even like this photograph. So you understand, this is simply a body and life that he can actually survive without the assistance from any other people. So in last year, in our recent statistics, we actually experienced to amputate around 550 patients, and most of those amputations are related to the upper limbs. And whenever we save some of those limbs, but they actually ended up on with this sorts of severe form of deformities, and these deformities are very difficult to correct and to make it functional or sensate. So they are living with those devastating contractures, and even they have limited capacity to use the prosthetic limbs. Access to the prosthetic limbs are not so easy for them because they are a bit expensive. However, we are trying to provide some of them with some prosthetic limbs, mostly for the students, but it is in a very small capacity. So the approach to this burn prevention actually to be effective in some particular areas should be based on the sound knowledge of the etiological patterns. That is why we are trying to launch some researches, because you understand the number of researchers in this part of the world is really very few. We mainly based on our hospital data. So it requires more research to find out the exact cause, and the community-based studies to find out the reality from the field. And we must consider the geographical variations and the socio-economical differences in the burn epidemiology, because the situation in Bangladesh or situation in India, though they are the neighboring countries, but the situation is different. The situation in Bangladesh and in Nepal is different. So they are experiencing the problem in their own way, and we are facing in another way. So I think these things should be more specified to find out the exact cause and the reasons behind those incidences. Then we will be able to design the appropriate form of prevention programs. So from our point of view, from our experience, from the world's largest burns and plastic surgery center, and actually we don't want to establish more and more hospitals or to increase the number of the burn beds, but we need the prevention. Thus we will be able to actually prevent the amputations and to prevent the expensive reconstructive surgeries. So I think this is the high time to start the prevention, because Bangladesh experience a very bad source of electrical burns in this part of the world. So we'll be able to work together and work in collaboration for a better world. And there is a good news that, and I think it is the first time in the history, any of the burn specialist or a plastic surgeon becomes the health minister of a country. And in our country, my boss, actually, Dr. Shamatulal Sen, who is the person behind building this big hospital, becomes the health minister 1 month back. So he just visited the World Health Organization and delivered his speech, and he discussed with the Secretary General of the World Health Organization, and he emphasized on the prevention of burn injury, not only in Bangladesh, for the world. So I hope we will be able to work together in a near future. Thank you.
Thank you so much, Dr. Tanvir. That's really impactful talk about the burden that electrical burn injuries pose to your local communities. And I feel there's a lot that resonates between Danielle's talk just before about really understanding, truly understanding the local community experience, what's causing the burn injuries, and then we can have targeted, inclusive prevention strategies for that. So thank you so much. We're going to move on to our next speaker, and that's Ms. Shobha Chamanya. Ms. Shobha is presently a senior surgeon who's attached to the Choitram Hospital and the Research Centre in Indore in India. She actually has established the first comprehensive burn care facility in central India in 1988. So she is wise as well as absolutely incredible. And Ms. Shobha will speak to us about burn prevention in India. Shobha, the floor is yours.
Thank you so much, Kirsi, for your kind introduction. I'm sorry. Yeah. So I bring greetings from Choitram Hospital, Indore. Good evening, everybody. And I would be sharing with you the prevention scene in India. So how big is the problem in India? India is supposed to be the highest ranking in the population. And the problem of burns is really big. 1.9 million and more is the incidence with a prevalence of 1.5 million. So this is like 3 to 4 million burn patients are there in our country.
Shobha, would you mind sharing your screen? Apologies for interrupting.
Sorry. I think I did. Okay.
If you like, I can share your slides.
Yeah.
Oh, there it comes. It's coming up. Thank you.
Is that okay? Yeah. Thank you. Sorry for that.
If you could just expand it to the PowerPoint setting.
Yeah. So the problem is really big. It is more than 1.9 million, the incidence, and the prevalence is 1.5 million fire-related. These are only fire-related injuries. In 2019, there were about 23,000 fire-related deaths in our country, which is 1/5 of the global mortality of fire-related injuries. So we are having a large problem. Who get affected by this? Women at home, generally domestic burns with unsafe equipments and unsafe practices, with some injuries due to domestic violence and dowry-related conflicts. Men, as Dr. Tanveer elaborated, are mainly affected at workplace, whereas children, again at home, generally scald injuries, but we do see a lot of flame burns due to fireworks, at home due to cooking, open flame equipments, and also electrical injuries happening here quite often. What are the reasons in our country? Equipment like this is a very unsafe pressure stuff, very commonly used in the commercial areas and leads to burst. This is another equipment that is the chimney. This is like for illumination. This is kerosene chimney, and usually topples and the lid opens and leads to fire at home. Sari is the domestic females, Indian females garment, which can be worn in a safe way if you tuck out all the flowing ends. But some people can have these flowing ends around the open flame, and that can cause fire. And this is the scene in India too, which Dr. Tanveer elaborated so much. So what are the strategies that we have been doing? And in India, the prevention strategies started almost more than 50 years ago by the pioneer, the late Dr. Manohar Keswani from Bombay. And many people in various parts of this country took over from him by educating students in the schools and in colleges, educating in your own hospital, the patient's families that are in a very sensitized state because they have gone through burn injuries, and the other families visiting the hospitals, using the burn day, National Burn Day, and the Plastic Surgery Day as the event for introducing prevention strategies to public. And now we have many plastic surgeons publishing books on burn prevention, brochures, making interesting videos on all the public platforms, social platforms, for making people aware in all the regional languages, because India is a vast country with the largest population and has many languages. So it is in all the languages. They just want to let them know what is the risk and how to modify the behavior to develop some safe habits. The most important question they have in times of panic is, what do we do now? And what is the best first aid? So it is emphasized that pouring water on burns is the first aid, and please use that. And what not to do, because people tend to do a lot that should not be done. This knowledge has to be repetitive to be effective, because once you listen to something, the knowledge, attitude, and practices are not very easily converted. Knowledge is not very easily converted into safe practices. So this needs to be very repetitive and in using all forms of education. But that is not enough, and therefore some passive strategies have to be supported to really make it effective. And these strategies are some engineering designs that I'll be sharing with you very shortly. Environmental modulations, like the government of India now has provided electricity for the rural areas. So the need for illumination by the chimney is not required anymore, and therefore those burns are not seen that we saw 10 years ago. And we need legislations and regulations like in the developed world that can really effectively prevent injuries after studying the epidemiology. I would share some of the strategies that we used in past. In 2009, we had conducted this study supported by WHO. We picked up the unsafe illumination lamps from the marginalized communities and educated them on using these safe lamps, provided them with solar or LED lamps, and which could be charged whenever there was electricity for 1 or 2 hours during the day. And this is the quality of improvement, illumination in the room. You can see that this is nicely illuminated. The lamps lasted for more than a year with zero maintenance, and therefore they were welcome. The incidence of burns, with 23 persons in that large community had sustained burns before. But after introduction of this lamp, there was only one case of self-harm leading to burns post-intervention. So this was a very successful project. Another project that we did in for community around our hospital was to try and prevent scald injury in small children. People who lived in 2 rooms, we provided this barrier between the 2 rooms, and people who lived in 1 room accommodation, they were given this play pen, which was shared with children from the whole community. And the reason of incidence is because the hot food is stored on the ground level and the cooking is done on open flame on the ground level. This study was done by a visiting fellow. She was doing her PhD. They found a significant decrease in burn injuries with this during the intervention period, which was only 6 months. Before the intervention, there were 18 children who had sustained small burns, but after the intervention, only 2 when they did not use the intervention. Looking at this large incidence, the Government of India in 2010 started a national prevention program for the management of burn injuries with the idea of strengthening the preventative and curative rehabilitative services for burn victims and developing 75 centers in next 5 years. So they decided that it is better to strengthen the existing centers in the medical colleges and district hospitals with resources, equipments, and trained individuals. This is still going on. A study recently done about the resources available for burn care, there were 67 burn care facilities. These are only the large facilities, 30 in public and 37 in private. They have 1,339 beds for burns and only 297 ICU beds for burns. 16% of the population lived within 2 hours of a facility having ICU and skin bank, which is required for proper care of a major burn injury. 70% of the population only had a burn care facility possible within 2 hours of their place of living, but 30% of the people did not have a hospital within 5 hours of their home. So transportation is going to be a big challenge for reaching a burn facility. The cost of care is another big issue because it is prohibitive. Anywhere in the world, burn costs a lot, and India or any other middle income group of country will also face the same. 37 private hospitals, patients will have to pay out of pocket, and this is one of the big challenges. Government has started some health insurance scheme for them to be supported, These are few funds which provide a moderate amount of support, but once you accept this support, the patient cannot be paying anything extra, and therefore it defeats the purpose of effective burn care. Therefore, we're looking at public-private partnerships and a lot of philanthropists, NGOs, Rotary clubs, research, corporate social responsibility contributes to free reconstructive camps for post-burn deformities and sustained prolonged years over convalescence. Many thanks to these people who are looking after the large number of dailies due to burns. And for training and effectively improving the human resource, the Burn Fellowship Program is getting rolled out, which is going to be hopefully training the whole team so that the burn care becomes more effective. So the way to go forward is to advance all three sectors: prevention, acute management, and sustained rehabilitation, so that the incidence, severity, and mortality, disability, everything gets reduced. In order to do this, we will have to improve starting from the transportation to burn care facility. We'll have to strengthen the burn care facility uh, by improving the existing centers in resource, infrastructure, and training of the individuals working there. Maybe provide specific health providers for the remote areas, like those who are 5 hours away from the any burn care facility. They should have health providers who can manage minor burns locally and prevent deformity development. And the large center can then focus on quality outcomes. Thank you very much, Avoid ADN, for allowing me to share this with you. And thank you very much for patient listening.
Thank you so much, Shobha. That was fantastic. Another insightful talk into the injuries and the challenges that face you as the burn care professional, your colleagues, for the vast region where your patients potentially could be admitted from. Thank you so much. We shall move on to another colleague of mine, Jonathan Bayou. Jonathan is a research assistant professor in nursing and also is a clinical academic nurse specializing in burns, plastics, and reconstructive surgical nursing. And he has a subspecialty in geriatrics, pain management, and palliative and end-of-life care. He's currently affiliated with the Presbyterian University in Ghana and also the Hong Kong Polytechnic University. And Jonathan is going to be talking about my personal subject of interest, pre-hospital burn care in Ghana. Jonathan, it's over to you.
All right. Thank you. Thank you very much, Chris, for the introduction. And thanks to the ADN network as well for the wonderful opportunity to share on pre-hospital care, focusing on Ghana. Thank you. Thank you very much for sharing the screen. So yeah, just next slide, please. Yeah, so pre-hospital care is pretty much a very critical part of the burns management process because very often, virtually all burn injuries, if most of it will occur outside the hospital. And because it's a form of injury, usually there'll be bystanders, there'll be some responders who want to try to do something to the patient before the individual is conveyed to the hospital. Sometimes these bystanders may have very good intent to help, but usually it may not go well. And pretty much how pre-hospital care goes can affect the entire trajectory of the burns management process. So usually when we talk of pre-hospital care, I think the focus often goes to just the care that is rendered, but it usually goes beyond that to include the logistics, the rescue competencies of the individuals or the bystanders, the responders who are undertaking the rescue mission, and then the scene management skills, because usually pre-hospital care has to be organized around usually around disasters and very complex, difficult scenes where there'll be the public will want to see what is going on, and people will just also want to help. So there's it's very important that in addition to the care provided, there's also scene management skills and rescue competencies as well. More specifically for burn care, pre-hospital care will usually capture making sure the affected person is away from the source of injury, which sometimes may include smoke, especially if there's risk for inhalational injury or smoke inhalation. Putting out the source of injury or the fire, if that's the case, delivering the first aid, preventing contamination, and so on. And appropriate pre-hospital care immediately after the injury is very important to prevent further harm, complications, and even death as well. Next slide, please. More specifically in Ghana, our challenge has been that even though the standard guidelines are available, as clinicians, we know what the guidelines are, we know what first aid has to be given, or what sort of pre-hospital care usually have to be rendered. It's a very big challenge for the public who usually serve as the first responders or the bystanders. Usually they don't know what is going on, and out of a good heart, wanting to help, people usually end up applying all sorts of things to the wounds. So by the time the burn patient passes through the peripheral facility and gets to us at the tertiary setting, usually you find things like infection already starting in the burn, localized infection. So usually within our local setting, usually we find patients coming in with egg being applied. Sometimes you find toothpaste, sometimes all sorts of household items, soy sauce, and all of it coming to the hospital. And sometimes it makes the wound cleansing even more difficult, and which means that we are going to induce so much pain to the affected persons. And another concern that we do have, another issue we do have in Ghana is about the lack of preparedness for disasters. Our system has been a bit reactive in this sense, rather than being proactive in preparing for disasters. And I'm going to show a couple of pictures to show the damage that mass explosions have caused in several parts of Ghana, which have led to deaths and injured persons as well. So because of our lack of preparedness, most instances of disasters or explosions usually is the untrained public who get to be the first responders or the bystanders who want to help out. And because they are untrained, they tend to do what they think, in layman's term, what they think is most appropriate to be done. We also do have a problem with poor address system. There have been instances where explosions happen and the fire service will miss their way because they get the wrong address, or sometimes they tell them this is the place, and navigating to get to the site of injury becomes a very difficult challenge. Road system is equally poor. The communication system is also quite not so good. And all these things usually impact on the arrival time of the professional responders at the injury scene. Next slide, please. A couple of major explosive incidents that have happened in Ghana over the years. First one is in 2015, where massive explosion at a fuel filling station in the capital city of Ghana, Accra, in a major industrial setting where lots of businesses go on. It was during the daytime, heavy rainfall with fuel discharge in the rainwater led to very massive explosions. And because of the location of the place, it made it very difficult for trained personnel to actually get there. And it meant that very untrained persons were virtually left on their own to support these affected or burned patients. And we lost more than 250 people, with several hundreds who were also injured and had to be admitted into various parts of the various hospitals in the country. Next slide, please. The second incident also occurred in 2017, which also happened in the capital city as well, also linked to a fuel station or a fuel tanker, where people were equally trapped within the location of the injury. And it took it took a while for the ambulance service, the fire service, the trained personnel to actually get to the scene of injury, leaving the burned persons or the people with the injury in the hands of untrained people who were trying to do what they thought they could do to help the injured persons. And more recently in 2022, next slide, please. In 2022, we had another massive explosion that actually leveled down an entire village in the middle belt of Ghana. We are still living with the aftermath till date, and we are hoping that something like that will definitely not happen again. And as you can see from the surroundings, you can tell the state of environmental hygiene. So if you are to render pre-hospital care in this sort of environment, even before the patient gets out of this environment, gets to the hospital, you definitely want to believe that there has been a potential high risk for infection of the burn wounds even before the patient actually gets to the hospital. Next slide, please. Beyond the shores of Ghana, other African countries equally have very difficult challenges with pre-hospital care as well. And a very recent review that was undertaken across Africa reported the use of various household items, which of course reflects the Ghanaian situation as well, including egg, charcoal, gentian violet, toothpaste, and even engine oil, which is popularly known as dirty oil, on the wound surfaces before the wounds actually, before the affected burned persons get to the hospital. And it seems to be not just a Ghanaian issue or not an African issue, but even in developed countries like Australia and the UK as well, there has also been quite some concerns about the ideal first aid that are being rendered before a burned patient gets to the hospital. Now, what is the impact of all these? Next slide, please. Very poor pre-hospital burn care can lead to wound contamination and introduction of wound stresses. And we see this most of the time in the clinical setting. Even before the patient gets to the hospital, you can tell the wound already looks infected. Even before you begin the more advanced forms of treatment. And there's also very high risk of infection. So all these usually lead to frequent usage of antibiotics as well. Even when there's no culture result, but just for the sake that we believe that this person is coming in with a very high risk for infection, usually our plastic surgeons will want to begin broad spectrum antibiotics in addition to the usual treatment. And there's also a very high potential or risk for developing avoidable complications and lots of time-sensitive issues and disabilities as well. Usually, people want to think that burns rehabilitation is a very distinct phase in the burns management process, but then it's supposed to occur right from the start. Right as soon as the injury occurs, and then it goes alongside the other phases of acute care, emergent care, and so on and so forth. So if the pre-hospital period, and especially for Ghana, where sometimes when the burn patients are moved, they don't get to the tertiary facility where we have the advanced burn care service available. They get to the peripheral settings where usually burn care support or burn care specialization is not very common in those areas. So they go to the general site first before they are transferred later on to the tertiary facility for advanced care. And usually by the time they come, all forms of issues may have already started before very advanced treatments begin. And it all leads to virtually most of the time leads to longer periods of hospitalization. And for a developing country like Ghana, longer periods of hospitalization usually leads to high cost as well. Not all the burn care services are covered by our current health insurance. So it means that there's a lot of out-of-pocket payment coming from the patients as well. And also death as well, because very poor support right from the start and all the associated complications virtually can terminate in death, especially if specialized care is not provided as soon as possible. Next slide, please. So looking forward, I believe there's these issues present as opportunities for further work in terms of research and clinical practice put together, policy-wise as well. And it's interesting to see the preceding speakers talk about the need for all these, especially for policies put together. So in our context, it will become very important to increase public knowledge. How to do this will seem a bit daunting at first, but I believe a starting point would be to include burns knowledge, simple burns knowledge in school curriculum, so that as the students learn, they'll be able to they will grow with the knowledge and be able to apply it as the case may be, rather than to wait for the event to occur before thinking about how to train people. And then also public education platforms can also be considered. Ghana is quite as a very religious country, so churches, mosque can definitely be a place to consider consider this form of public education. Then to also improve our emergency response system, it's going to take a lot of effort, and it's going to take a lot of community engagement, stakeholder engagement, and a lot of policy work to drive some of these improvements, and then to improve the healthcare capacity, especially at the peripheral levels, to ensure that our burn patients receive specialist care, at least even at these places before they get to the tertiary facility, and then increase resources and then bed capacity at the tertiary facilities as well. The final slide, please. So in conclusion, pre-hospital care is a very critical part of the burns management process. And looking at the evidence so far, there's a lot of work for us to do in our Ghanaian setting. And we are counting on community participation and collaboration to improve the whole situation. Thank you very much.
Thank you, Jonathan. That was really insightful. And I certainly am aware of much work that's gone on in the field of community response and citizen response outside of the formal services, because like you say, quite often in terms of mass casualty disasters, often the citizens are left to help out in quite a long time before the professional services can arrive, or maybe there's delay in access to the scene. So I'm so glad for you to have talked to us about the disasters that you have experienced in your communities and how you're still dealing with the consequences of some of those to this day. So thank you very much. And we will go to our final speaker, the wonderful Zifili Sichinga. Zifili is a senior nursing officer at the Queen Elizabeth Central Hospital in Malawi. She's got 8 years experience in burn care. She's also a burn nutrition fellow and so passionate about improving burn care through mentorship and provision of direct nursing care and leadership and training and research. I'm aware of her work with the Interburns, and if you don't know of the work that the Interburns do, please do check them out. They're an incredible organization that supports professionals who care for victims of burns in the lower and middle income countries. But for now, Zifili, the floor is yours. Please talk to us about burns in Malawi, your challenges to improve burns care.
Thank you so much. First of all, I just want to thank you for giving me an opportunity to speak about the burn care, especially on the challenges in Malawi. So, next, please. Slide next. So, as we are all aware that most burns are from the low middle income countries, and more than 90% However, 2/3 are from Africa region, and it accounts for 15% of the burns. Apart from that, Malawi has the highest burn mortality. That is in Africa. It accounts for 22%. So Malawi has a population of over 19 million people, with 84% that lives in the rural areas. That means that most of the people are from the rural areas and they are from the primary health care. So Malawi has only 2 burn centers. That's Queen Elizabeth Central Hospital and Kamu Central Hospital. And their bed space is 27 and 37 respectively. You can just imagine out of 19 million, only 2 burn centers in the country. That's a big challenge. So burns claims 4.4% of all injuries in Malawi. Next, please. Next slide. So there are many causes of the burn injuries in Malawi, but mostly for adults, approximately 30% of the total burns it's adults, and 70% it's children. So as you can see, it's also correlating with what people say, that most of the burns are from the children. So from the adults, most of the burns are caused by flame burns, basically due to epilepsy and also electricity. While for the children, most of the burns are caused by scald burns, and that is due to hot water or maybe porridge. This is because of the open fire cooking practices at the ground level and lack of parental supervision. Next, please. So there are many challenges that affect to improve the burn care in Malawi. But the first of all, one of it is because of little or no burn prevention in Malawi. So to start with, in Malawi, we don't have the national burn policy. That gives a great challenge to improve or to engage in prevention strategies or prevention activities in the burns. And because of that, even most of the community, or maybe most of the people, they're not aware of the good first aid. So as such, they put on things that are not supposed to be put. And they put things like toothpaste, dung, and lots of things, cooking oil, and some of them, they're so infectious and they lead to infection. As a result, the wounds get infected, and this causes sepsis, even unto death. So the second reason, or the second challenge that we have in Malawi is delayed presentation. This is due to lack of knowledge by the nurses or maybe the skilled staff. So usually they refer the patients to the tertiary hospitals very late. As such, it's difficult for the care or to be given and to improve the burn care. Or most of the times they will they will send the wounds while the wounds are already complicated. So it's a big challenge to improve burn care. The other reason is because of no trainings that are provided to the nurses or maybe the staff. So because of that, they have very poor knowledge in and care, and also very poor knowledge in teaching the people to prevent the burns. On the shortage of staff, and I've already said that we only have 2 burn centers in Malawi, and unfortunately, even in the burn centers, it is difficult for people to, especially nurses. I'll talk much of nurses because I'm a nurse. So it's very difficult for even nurses to go to the burn centers, the burn wards. This is because everyone says that burn care is so hectic and it's hard. So they prefer going to or working to other wards. So most of the times we'll have shortages of nurses to work in the burn care. So this is a quite challenge we have. The other problem we have is poor nutrition. poor nutrition support and HIV. So for poor nutrition, most children are already malnourished because Malawi is one of the poor countries. So most people, they're already malnourished. And apart from that, even burns, they also deplete nutrition status of a child. So when someone is already malnourished and has got burns, it's very difficult to succumb the infections. As such, the child will develop infections or sepsis, and it's very difficult even to prevent death. Even HIV and AIDS. So HIV also slows healing and complicates the wound further. So when a child has, or when a child or someone has got a burn and also has is HIV positive, it's very difficult, as I already said, that their immunosuppression. Burns itself also suppresses immunity. So it's like a double trouble. So in the end, this patient is very susceptible to infections and fails to fight against the infections. As such, it's difficult to prevent death. So the other challenge is poor brain care from referred patients. I have already said that most of the primary health care centers, they are not trained in brain care. As such, even the care, when the patients are referred, they are in a very bad state. And because most of the time they are not well resuscitated. And because of that, some patients, it can also lead to kidney failures. Even some, they'll go into shock and even death. So this contributes much to much of the deaths that we have. And just for you to know, most of the deaths that happens in the tertiary hospitals, patients who are referred, they are at least 4 times than the patients who are admitted at the tertiary hospital. So you can agree with me that if patients from primary health care, they're not well taken care of, it's very difficult for them to survive or to prevent death. The other challenge we have is poor infrastructure and also shortages of staff. For poor infrastructure, I've already said that we only have 2 burn centers in Malawi. That means that the whole country doesn't have burn centers. So because of that, they don't have good structures for good care of burns. And this also leads to many infections in the burns. Also, they lead also to many deaths of the burns. Next, please. So there are many, a lot has to be done to improve the brain care, especially in Malawi. First of all, I already said that we don't have the national brain policy. So there is need, of course, I know that it's underway, but I think it needs to be quickened up so that at least there can be brain prevention strategies, like prevention strategies like through mass media, radios, dramas, television, and posters. Also, because most of the adult burns, they are caused by epilepsy, so there is need of mass education on epilepsy. On top of that, some of the, though I didn't mention, but some of the causes of burns in adults, though they are not as much, it's because of the biomass like petrol. So there is also need for educating people to prevent from having or maybe keeping these in their own houses. The other where we can improve brain care in Malawi, we need to improve in referral system, because sometimes the patients are referred very late to the tertiary hospitals, or maybe they don't have a good referral system. As such, they don't get attention or assistance as quick as possible, and this leads to complications. So the other thing we need to do is training of brain nurses and clinicians. I should commend some organizations that stand with Malawi, like Interburns, has been so helpful in Malawi, because I am one of the people that has been trained. I already said that we don't get trainings from the government yet because it's not in the burn policy. They don't have the national burn policy. But however, organizations like Interburns, they do go train people from low-income countries. And I am one of the beneficiaries and a well-trained nurse. So we need to have more of these trainings. And the best thing we can do also is maybe to improve on the syllabus, nursing syllabus, so that everyone who is coming from the school or college should be equipped of right knowledge or skills to take care of the burn patients. This can lead to prevention of more deaths in burns. And the other thing is we need to have more burn centers and good infrastructures. In Malawi, we have three regions: central, southern, and northern. However, we only have 2 burn centers from the central and the southern. So we need to, at least even in the northern region, to have another burn center so that at least people can be referred there and be assisted for tertiary care. Next, please. Yes, so in conclusion, Malawi still leads in burn mortality in Africa, despite that burns are preventable. And unless there is combined effort from all stakeholders, there will still be challenges in burn care in Malawi. Thank you.
Thank you so much, Zifali. Thank you for sharing that. And very nice to see you as a representative of the Interburns training and the beneficiary of that. So you can now spread the good work amongst your colleagues. Like you say, there's lack of training currently available, but it sounds like there's light on the horizon, that more good things may be coming. And I definitely wish you all the best. So thank you so much for sharing.
Wanted to take an opportunity. I just wanted to take an opportunity for that. I said about Interburns. So like this year, Interburns is planning to have a training in Malawi. And that training will not only focus on tertiary hospitals, but the whole Malawi people, representatives from all the districts. So I believe that will also help in promoting good burn care and prevention of the burn deaths. Thank you.
Fantastic. Thank you so much, Zifali. Now, we've been so keen on talking about preventable burns and preventable burn deaths that we have almost run out of time. So, Dr. Gupta, I'm very sorry, we won't get time to quite address your question, but we will get back to you via email. So anybody who's registered and asked the question and we haven't answered, I apologize. We will get back to you via email instead. So for now, I will take you to our poll. I think that's the next thing for us to check that you've been listening.
Thank you, Chrissy. So Lauren, I welcome you to run the post poll. There's only one question, so it shouldn't take long. So you're looking for more or less same response rate if we can. So please.
So we've got a 53% participation rate so far.
Mm-hmm. You can keep going. What is fascinating is that, we started with 48 participants, so we just lost only 6 participants. So we could expect about, let's say, 78%, 70%. Can't see the
Okay, so we now have 65%. We're at a minute, so we can keep it for another 50 seconds to get
50
it up.
seconds, yeah.
If you can see a poll on your screen, if you could answer it, please, just by clicking 68%.
Oh, Very good. 2 more percent, 2 percentages, that would do. We can close at 70%.
Okay, so 20 seconds left. We're at 75% now.
Very good. That's fantastic.
10 seconds left and 78%. I
That's
think it's
brilliant.
almost at what we were earlier.
Yeah, fantastic.
I'll just end it here.
Yeah, brilliant. Thank you very much. Chrissy, over to you. I could see now the screen. Very nice. Okay.
Thanks. So it's the final concluding remarks for myself and you, Nivedita. So I feel like personally I have learned an awful lot, and it sounds like actually that all of our communities need to work much closer together. The prevention work, the fire safety professionals, as well as the initial responders and the burn specialists. I've often I believe that actually the only person that sees the full pathway is the burn injured patient themselves. From the time of injury to the time of recovery and thereafter, they're the only ones that are present throughout of our very unique and individual services. And actually what these presentations have shown us is that we all still are a little bit in silo working, and we need to reach out to other people who do really good work, who touch upon our patients' lives. And actually, if we benefit from each other's experience and knowledge, that experiential knowledge that many speakers alluded to, actually our prevention efforts will be way more targeted, way more effective, and will be more effective and more helpful to each other's work as well. So I'm incredibly grateful to all of the speakers and certainly to all the attendees for coming and listening to us about it. I hope you all will be able to take away something helpful from this session. I'll hand over to Nivedita to conclude our session.
Thank you very much. I fully agree with Chrissy. There's so many synergies. I was like totally surprised because I've never taken part or listened to any of the seminars or knowledge exchange events that Chrissy runs, but I do follow her on LinkedIn. So what did I learn? It was fantastic. I think in Daniel's PowerPoint slides, what drew my attention is access to healthcare and social determinants of health. And they also use DRR approach, which is fantastic. So there's an overlap. For Dr. Tanvir, again, fantastic. Prevention is the key, not building many more hospitals. Yeah, that was, again, fantastic. Something cross-cutting. We can all connect to that, especially in low and middle income context when the budget for health investment is shrinking every year. Burn prevention in India, Shobha's presentation is again absolutely amazing. I quite like the way the prevention strategy has been disaggregated as active and passive, and also bringing lots of evidence from her research projects. Again, something that, you know, although I'm not from, public health, I have been in the field of public health of social sciences, but I do not have MPH. Yeah. And I am not a medical doctor, not a clinician, but I have been working with public health clinicians, epidemiologists. And again, I see synergies there. It's fantastic. And I learned a lot about the prevention strategies that Shobha's organizations have taken up. And I've taken lots of pictures, and we will be putting into practice for our ADN's outreach workshops for snake bites. And then again, for Jonathan, what an amazing concept, pre-hospital care. We use it all the time for snake bites. Nearly 70% of deaths from snake bites take place in a pre-hospital care. That was, again, an eye-opening for me, and how you explained what are the challenges for pre-hospital care setup also in disaster setup, yeah? If there's a small-scale disaster and a large-scale disaster, through your pictures, it just told us so much that there are so many challenges for attending to a patient who has been at the time of disaster. It's very challenging. So that's something I learned a lot. And burns in Malawi, again, fantastic experience and evidence from syphilis context, once again, it brings preventative aspects, amenable aspects, and governance aspect, which I'm very interested in. We can have hospitals, but if there are no workforces, it's not going to help us. You can have hospitals, but if there is no access, there's no roads, people can't reach there, then it is a governance issue. You can have hospitals if there is no stocks, no supplies, it's a governance issue. So I think it's fantastic what Sifili, demonstrated through her experience in the context of Malawi. And of course, Chrissy, you always brought interesting insight, and I enjoyed it very much. And I hope you all who have been with us, it's fantastic. We didn't drop not many participants dropped out, but otherwise you have been with us. We are very grateful. We enjoyed a lot. I hope you did too. And we will be posting the results of our poll on our website. Keep an eye on our special session page for the burn deaths, burn injuries. And also, as Chrissy said, just want to second that, yes, we will be copying and pasting all the questions that you have posted on the chat box. We will get the answers from our relevant expert and put the responses beside your question, and we will send out an email, and also we will post it on the website. So with that note, thank you very much. Please stay in touch, join ADN, celebrate the global campaign, International Awareness Day for Avoidable Deaths, raise awareness of avoidable deaths, which is basically burn injuries and deaths. So thank you very much.
Thank you, everybody. And that concludes our session. Well
Yes.
done, and thank you to the speakers.
Goodbye.
Goodbye. Thank you very much. Okay.
Thank you.